Okay, so good afternoon, good morning, and good evening to all of you here who are joining us. My name is Brad Barton. I'm the president for ConvaTec Americas, and I want to just thank you and welcome you here to our webcast and our roundtable discussions today. The topic and the title, Why Risk It? Minimizing both the clinical and economic impacts of wound infections. As many of you know, this is the third in a series of webcasts we've been doing on the growing prevalence of wound infections around the world and concentrating on both that clinical and economic impact it has on us and you in operating our healthcare systems. I'm also happy to share with you today that we have more than 3,000 attendees in over 20 different countries that are participating in today's webcast. And we will address the challenges associated with the prevention and the management of wound infections. And in addition to that, we're going to share with you some new and very compelling data illustrating the effectiveness of some of the advanced technologies available today for fighting these infections and helping you, again, overcome the hurdles of both clinical and economic impacts in your institutions. So, with that, and without further ado, I want to introduce our moderator for today, and that is Dr. Harry Kovelman. Harry is the Director of Medical Affairs for the Americas at ConvaTec. And so, again, without further ado, I'd like to turn it over to Harry, and let's get started. Okay? Harry, thank you.
Okay. Thank you, Brad, and a warm welcome to everybody. We're pleased to have with us today a distinguished panel of speakers, and I'd like to welcome each and every one of them. From these experts, we will learn about important changes in healthcare policy that affect all of us and make the need to minimize the prevalence of wound infection more important than ever before. We will hear evidence to support the important role that antimicrobial dressings have in wound infection and how a dressings technology can impact both clinical and health economic issues. Lastly, we will hear from those who are in the trenches every day in some of the top orthopedic and burn centers in the world and learn about their clinical experience and what they do to meet the challenges of wound infection and provide optimum care for their patients. Following the presentations today, we will open up the lines to take questions from the audience. I'm now going to introduce the first speaker. Our first speaker is Julie Scott Allen. Julie is a government relations director with Drinker, Biddle, and Reith, where she serves in the firm's Government and Regulatory Affairs Practice Group. Julie works with healthcare providers, hospital systems, medical device companies, and patient advocacy groups to help them understand health policy regulations and legislations that affect the healthcare industry. Julie is here today to speak to us about health policy issues that impact every wound care clinician. I now introduce Julie.
Hello, everyone. Welcome to all of you here with us in the room and watching from across the globe. We're here today because regardless of our professional interests, we share a common goal. Whether you are a surgeon, a nurse, an infection control manager, a scientist, or a non-clinician policy professional like me, we share the goal of wanting to work proactively to address preventable healthcare-associated infections. My interest in these infections comes from a different perspective than yours, given my profession. I am not an epidemiologist or a healthcare provider. I am based in the U.S., specifically in Washington, D.C., and I work to help policymakers understand the impact their decisions have on healthcare and the programs involved in healthcare. My efforts involve examining the economic drivers that affect healthcare and making recommendations that can help industry, providers, and patients in addressing challenges like healthcare-associated infections. I want to help kick off today's panel discussion by providing an overview of why it's so important that we work together across our professional interests to focus on healthcare-associated infections and implement solutions for addressing these infections. While my experience comes from addressing United States-related policies on healthcare-associated infections and other efforts being conducted in the United States, I hope to provide some insight to those of you who have joined us today from across the globe, near and afar. As we all know, the cost of healthcare is rising, and your role in addressing infection control is growing and becoming more critical every day. It's important for you to understand how you can impact change, what solutions exist to help you be successful. It is the goal of the speakers who follow me today to help you understand the options that are available to you. So the question that some folks have, because there are lots of different definitions floating out there, what are healthcare-associated infections? In the United States, we have several government agencies that bear some responsibility for overseeing and addressing these infections. The Centers for Disease Control and Prevention in the United States is responsible for surveillance activities and providing resources and guidance for addressing these infections. This agency defines healthcare-associated infections as an infection that patients acquire during the course of receiving healthcare treatment for other conditions. To a layperson, I have to say that definition is quite concerning to me. No one wants to think that they could leave a healthcare setting sicker than when they entered it. But the reality is, as a global healthcare community, we know precious little about healthcare quality and patient safety. Preventable infections occur even in the best healthcare institutions in the United States and across the globe. Of course, with heightened focus and awareness, procedures and policies are being implemented within hospitals and elsewhere to reduce the chance of these infections or other care-related errors. But if we're pressed on whether patient care is any safer than it was 5 to 10 years ago, how many of us could honestly answer yes? We certainly have a dichotomy between the success of biomedical science and the too often failure of patient safety and care. Think about the advancements in HIV/AIDS treatment. Think about the sequencing of the human genome. We can do this. But can we effectively develop interventions that save patients from preventable healthcare-associated infections? With our medical advancements, shouldn't we also be able to effectively address the risk of these infections? That question is being pushed here aggressively in the United States, and the U.S. government is establishing standards and guidelines, and yes, even penalties against healthcare providers who fail to succeed. In the presentations that follow, we'll hear more about ways we can proactively seek to address these infections. Healthcare-associated infections are obviously not limited to the United States alone. The burden for these infections is global. However, in some countries, it is challenging to understand the exact rate of these infections, given the lack of resources for comprehensive surveillance programs. Across Europe, the Pacific, the East Mediterranean, and Southeast Asia, the prevalence of healthcare-associated infections averages about 8.7% as compared to other types of infections. Looking at these rates outside of the United States, the most frequent are surgical wounds, urinary tract infections, and lower respiratory tract infections. And the literature shows that the highest rates of healthcare-associated infections occur in hospital intensive care units and acute surgical and orthopedic wards. Of no real surprise, we see that infection rates are highest among the most vulnerable of patients, whether that be by age or those with multiple chronic conditions. Looking at some specific countries, the statistics available are quite alarming. In the United States, there are estimated to be up to 2 million healthcare-associated infections per year in hospitals alone. And of this number, approximately 90,000 result in the death of a patient. The economic figures in the United States are equally staggering. The annual direct medical patient cost in hospitals for these infections alone goes as high as $45 billion. We likewise see growing rates of these infections in Canada. 1 in 9 hospital patients in Canada gets a healthcare-associated infection, and these types of infections are the 4th leading cause of death in Canada. The annual direct medical cost in Canadian hospitals for these infections alone is estimated to be about $1 billion. Reports show that the prevalence of these infections in developing countries is significantly higher than what is reported in the United States and Europe, at least 3 times higher in hospital intensive care units in other countries as compared to the United States. More than 1 in 20 surgery patients develop surgical site infections. One reason provided for the high rates of these infections is the proclivity of the surgical profession and the patient base towards antibiotic use. Reports show that high rates of antibiotic use are resulting in health-associated infection strains that are much more drug-resistant than those seen in other parts of the world. So let's talk a little bit about the true cost of these infections. These infections in hospital impose significant economic consequences on the healthcare system, affecting government payers, commercial insurers, and the patients themselves. Those costs are remarkable when you start to break them down and look at everything and anything that contributes to the cost of addressing even a single infection episode. Most people are familiar with the direct costs needed for patients in relation to healthcare-associated infections, which can be immense given the severity of the infection. But it's the indirect and intangible costs that aren't talked about enough: the disability, the pain, the suffering borne by the patient and their loved ones. What's not discussed in the deliberations by government officials and other payers is the human impact of these infections. The speakers who follow me today will help you gain a better appreciation of what can be done to proactively address the human impact and ultimately improve patient care and clinical outcomes. From prolonged hospital stays to long-term disability to even death, we can't put a price tag on the human impact of these infections the way we do direct costs, or it would be far greater. These infections have likewise resulted in a serious public health concern regarding resistance to antibiotics. Healthcare-associated infections are leaving hospital administrators to grapple for control in such budgetary areas as unplanned hospital readmissions, and solutions are needed now. With all the economic and other burdens facing the United States healthcare system and healthcare systems around the globe, one might ask, why is this a focus now? The answer to that question is actually multifaceted. Nations are concerned about a shift in demographics. The graying of the population, especially here in the United States, means a much more vulnerable population, as the elderly have much more complex issues and as a result are more at risk of infection. Chronic disease rates are higher than ever as individuals have multiple conditions, resulting in more frequent hospitalizations. These infections are recognized as a leading patient safety issue, as they create additional suffering and come at a very high cost for patients and their families. Patient safety and improved quality of care is a lead objective here in the United States, as the government and the private sector examine new care delivery models that are meant to improve healthcare outcomes and reduce overall health expenditures. As I mentioned before, the financial losses due to the healthcare-associated infections are tremendous. The World Health Organization states that the direct costs alone total approximately 7 billion euros in the European Union and about $6.5 billion in the United States. Targeting these costs is a priority across the globe, particularly addressing the infection costs that are linked to high-volume, complex procedures like hip and knee surgeries, patient injuries and trauma-related care where the risk of infection is far greater, preventable adverse events that include these infections, and patient readmissions to the hospital due to healthcare-associated infections. Until recently, much of the analysis about these infections had focused on the inpatient setting at the time an event actually occurred. However, with a growing focus on the need to reduce readmission rates, the linkage between healthcare-associated infections and high readmission rates is leading to greater scrutiny. Within the context of discussions around healthcare reform across the globe, there are similar themes being uttered and programs being administered. These are improved patient safety, a closer examination of the quality of care that's being delivered, a revised and renewed focus on how to provide patient-centered care that's necessary for the good of the patient both in the short and long term, and of course, how we all do this and at the same time reduce healthcare costs. The argument here being that prevention saves dollars and improved care delivery will ultimately reduce expenditures. In the United States, these priorities are being defined within the context of a triple aim. That's been presented by the government. That triple aim consists of three overarching and intertwined goals: better care for individuals, better care delivery, and reduced per capita healthcare costs. Policies have been instituted in the United States, particularly over the last 6 years, that have sought to impose pressures on hospitals to reduce healthcare-associated infection rates and associated conditions. In 2007, the U.S. government announced it would curtail Medicare payments to hospitals for specific infections or infections that are characterized as conditions a patient acquires while in the hospital that could otherwise be reasonably prevented. As a result, hospitals must report a present on admission indicator for all diagnoses on a medical claim. The United States has taken this even further now, imposing a penalty on hospitals for certain conditions acquired while a patient is in the hospital. The focus by the government has been on conditions that are high volume, high cost, or both, would result in higher payment due to secondary diagnosis, and those that could have been reasonably prevented through evidence-based guidelines. In an election year, Americans are hearing and seeing a steady stream of news headlines and commercials about the new health care reform law, and specifically about new benefits and coverage opportunities. But the new law in the United States also includes a multitude of other programs and policies that are meant to change the U.S. medical care delivery system and how it operates, particularly on issues like healthcare-associated infections and hospital readmissions. The new law specifically establishes penalties for those hospitals with the highest rates of healthcare-associated infections. Starting in 2015, the quartile of hospitals with the highest rates of these infections, or those that are characterized as conditions, will be penalized by 1% of their federal health care payment from the Medicare program. And this is a penalty that is gradually introduced, focused on specific conditions up front. The U.S. government estimates that this penalty would result in an average penalty to a hospital of approximately $209,000. Hospitals are in a race against each other to ensure they are not included in the top 25% in relation to high levels of infection prevalence. The new law also requires that infection statistics be made publicly available on the internet, increasing infection reporting requirements. The intent of this reporting system is for the public, both patients and employers, to engage more directly in an effort to reduce these infections, encouraging them to ask questions and to seek out high-quality care. In the United States, the focus on these infections will only grow. It will not lapse. The concept behind the triple aim I mentioned before is embedded in every healthcare delivery reform proposal that's been introduced, from bundling hospital payments around an episode of care to creating patient-centered medical homes. Controlling healthcare-associated infections is vital to the success of these delivery reform models, and these models, as well as readmission policies being put in place, will also require hospitals to meet quality standards or face penalties. So healthcare-associated infection penalties are not the only threat hospitals face. The United States government may choose to expand the healthcare-associated infection penalties on additional facilities to include home health agencies, ambulatory surgical centers, and skilled nursing facilities. The U.S. is expanding the number of reportable healthcare-associated infections where additional payment will not be allowed. This includes MRSA and hospital-acquired C. diff, surgical complications including wound infection from total hip and knee arthroplasty, as well as additional types of surgical site infections. While the hospital readmission program being put into place now only focuses on a few conditions, beginning in 2015, the U.S. will look broadly at all hospital unplanned readmissions and specifically add conditions and procedures it believes represents high cost and high volumes of readmissions. This includes elective total hip and knee arthroplasty. The United States is also adjusting a survey instrument that it currently uses, which is in the US, to collect data on patients from their experience in the hospital. Survey questions are being added to the instrument that will focus on a patient's experience with pain management, discharge instructions, and other factors that can be directly associated with readmissions concerns. The penalties being established and expanded will put a great strain on hospital systems going forward. Hospitals will need to find ways to make up financial losses and aggressively implement cost-effective solutions to avoid these penalties. Where the U.S. is being aggressive in imposing significant penalties on hospitals as well as mandatory reporting requirements for public scrutiny, other countries seem to be focused more on building surveillance systems and outlining standards for the prevention of healthcare-associated infections. Budgetary limitations seem to be the primary reason for the difference in approach. Most countries actually lack surveillance system for healthcare-associated infections, and those countries frequently struggle with how to standardize that data for accuracy. These challenges are far greater in low and middle income countries. Yet we know that certain types of healthcare-associated infections, like surgical site infections, are the leading types of infection in those countries with limited resources. As examples of surveillance activities, I found that in Canada, a surveillance program was established in 1994 to look at certain types of healthcare-associated infections present in the Canadian healthcare facilities and their frequency. In Colombia, surveillance and epidemiology control programs have operated to target healthcare-associated infections. On the prevention side, Chile has established mandatory requirements for public hospitals to form committees to set standards in healthcare-associated infection prevention. Countries like Colombia have focused on outlining prevention guidelines for healthcare workers. And still, other countries like Brazil, Venezuela, and Mexico have recognized healthcare-associated infections to be a concern and need of funding support to tackle. Similar to the United States, other countries are in serious need of cost-effective interventions to addressing healthcare-associated infection rates, specific to targeted conditions like chronic wounds and surgical site infections. So the bottom line is that no country can afford to ignore the burden healthcare-associated infections present in terms of its human impact and economic consequences. In the United States, reining in healthcare-associated infections is a priority in meeting the country's goals of improving individual health, improving care delivery, and reining in the growth of healthcare spending. Regardless of the role you play in the delivery of healthcare services, working toward resolution on the risk of these infections is essential. As you'll hear now from our distinguished panel, there are recommended solutions to successfully address these challenges. Thank you.
Privilege to present our next speaker, Phil Bowler. Phil is the Director of Infection Prevention Research and Development at ConvaTec. Phil is recognized internationally for his knowledge and work in the field of wound microbiology, infection, and infection control. Phil?
Thanks very much, Harry. Good afternoon, everybody. Julie's presented some very alarming statistics and devastating consequences associated with healthcare-associated infections worldwide. What I'd like to do in my presentation is focus on the cause of these infections, the antibiotic-resistant bacteria, otherwise known as multi-drug-resistant organisms, or superbugs, as we hear today, that are increasingly threatening in hospitals, threaten the lives of vulnerable patients in hospitals around the world. What I'd also like to talk about today is the association of multi-drug-resistant organisms with wounds, wound colonization with these organisms and infection, and then go on to talk about the role that wound dressings can play in minimizing the opportunity for infection in these wounds, and also helping to minimize the spread of multi-drug-resistant organisms from wounds, and thereby playing a role in infection control. So what is a multi-drug-resistant organism? Centre for Disease Control defines an MDRO as being resistant to one or more classes of antimicrobial agent. But these organisms are not just antibiotic resistant. They are problematic in that they can be more virulent, they have the ability to spread within the environment, they're tolerant to environmental conditions. Examples of these organisms, MRSA, methicillin-resistant Staphylococcus aureus, and also more recently community-acquired MRSA. This organism has the ability to spread in the environment, it's found more in the community, and it is more virulent. It produces one particular toxin, a necrotizing toxin, that is associated with skin and soft tissue infections. Another multidrug-resistant organism, Acinetobacter baumannii. This is an organism that devastates field military hospitals, causes wound infections, bloodstream infections, highly resistant, very, very difficult to treat. The extended spectrum beta-lactamase bacteria, these organisms have emerged over the last 20 years or so, increasingly resistant to antibiotics. One of these organisms in particular, Klebsiella pneumonia, resistant to carbapenems, was highlighted in the US media quite recently in the National Institute of Health Clinical Center in Maryland, where it was associated with 18 patients, 6 of which died because of this particular organism. So these organisms are problematic and they're threatening lives of vulnerable patients. If we look at these organisms with respect to wounds, this table was taken from an article that we published just last month in the International Wound Journal and covers a review of the presence of these organisms in different types of wounds. So you can see on the left-hand side the different groups of multidrug-resistant organism, but whether we look at natural disaster wounds, combat wounds, burns, chronic wounds, surgical wounds, these organisms are found consistently. But of course, antibiotics are not effective against them, or very few antibiotics are effective against them. So consideration, certainly in wound care, of topical antimicrobial agents, antiseptics such as silver and iodine, are becoming all more important to help to control these organisms where antibiotics are less effective. So, in terms of wound infection control, both systemic antibiotics and topical antimicrobial agents can be beneficial if we consider the wound environment and the bioburden within a wound environment that's depicted by the green zone in this particular slide. Chronic wounds in particular contain a wide diversity of microorganisms that come from the surrounding environment, from the skin, from the mouth, from the gut of the individual that has a wound. So organisms collect in wounds from many different sources. A key aspect of wound management is to prevent those organisms from becoming a problem and invading deeper tissue where they may cause infection. If there are obvious signs of infection, then systemic antimicrobial agents, antibiotics, are widely used. But of course, if wounds contain multidrug-resistant organisms, then how effective is the antimicrobial agent going to be? Also, if the wound is ischemic and there's poor blood flow to the wound, then again you're not sure how effective the antibiotic is going to be. So topical antimicrobial dressings can play an important part, both by controlling the wound bioburden and stopping the organisms from becoming a problem, but also by providing antimicrobial protection and containing those organisms, particularly multidrug-resistant organisms, within that wound environment and preventing them from disseminating into the wider hospital environment. So looking at wound dressings and infection control, wound dressings can work in two ways. They can work in a passive way or an active way. So by passive, by that I mean that the dressing doesn't have antimicrobial action, but there may be physical mechanisms, characteristics of the dressing that help to control spread of wound organisms or help to control infection. And then there are active mechanisms which involve an antimicrobial agent within the dressing. So if we look at some of the passive mechanisms of infection control, the first bullet in this slide relates to a study that was performed back in the late 1980s and published in 1988, where a hydrocolloid dressing, Duoderm, was actually used on wounds colonised with MRSA to actually contain the bacterium, which eliminated the need to isolate and barrier nurse the patients. The second bullet here, this was a study that was looking at the spread of bacteria into the environment when wound dressings were removed. Moisture-retentive hydrocolloid dressings were compared with gauze dressings, and it was observed that the numbers of bacterial cells that were shed into the environment when a dry dressing was removed was far greater than when the moisture-retentive hydrocolloid dressing was removed. And this is because the hydrocolloid dressing maintains a moist environment and there is less particulate matter that's dispersed into the environment. So even in terms of spread of organisms, the choice of dressing can be very important. The third point here, work that was published in the early 1990s, lower infection rates observed under moisture-retentive dressings compared with gauze dressings. And again, by retaining a moist environment, the host immune cells are able to work more effectively. So by retaining that moist environment, then the infection rate is actually lower. The next point here, the fourth point, in an infected wound model, animal wound model, it was shown that a hydrofiber dressing, Aquacel, was able to withdraw microorganisms from the wound and immobilize them within the dressing more effectively than an alginate dressing. Finally, clinical study showing that Aquacel dressing again was reduced with a significant reduction in surgical site infections in arthroplasty wounds compared to traditional dressings. So none of these studies involved antimicrobial agents, but it reflects the physical properties of dressings that may help to control infection. So here we look at two different types of dressing technology, an alginate and a hydrofiber dressing. Visually, the dressings look very similar. They're fibrous dressings, they're non-woven, and they're absorbent. But the way in which they handle exudate is very different. So on the left-hand side of the side here, we see an alginate dressing. When it absorbs exudate, there is exchange of calcium and sodium ions between the dressing and the wound exudate, and this leads to the production of a very weak gel around the periphery of the alginate fibre. But this still allows fluid and bacteria within the fluid to track through the dressing. With hydrofiber dressing, with dressings such as Aquacel and Aquacel AG, the fibres are actually able to absorb fluid into the core of the fibre, so the fibres swell. As exudate is taken into the dressing, the fibres swell, and they compress against each other, thereby forming a very cohesive gel, locking the fluid within the dressing and also immobilizing bacteria as well. And we can see on the bottom left of this slide a scanning electron micrograph showing gelled Aquacel, and you can see bacterial cells. These are Escherichia coli cells. They're encapsulated by the cohesive gel that has formed. So moving on to look at some of the active forms of infection control. Topical antiseptics today, such as silver, iodine, PHMB, are widely used in wound care to control wound bioburden. The advantages of these antiseptic agents over antibiotics, primarily that they generally have very broad spectrum activity. Antibiotics tend to have very narrow spectrum activity. And they also have a much lower propensity to induce bacterial resistance. But the relationship between the antimicrobial component and the dressing technology is extremely important. So while these agents may be effective in killing bacteria, once they're incorporated into a dressing technology, that dressing technology still needs to be able to make the antimicrobial component available to kill the bacteria in the wound environment. So I'd like to move on now just to talk a bit about evidence, patient-driven outcomes. A very interesting article that was published just about a year ago now by Van Rijswijk and Gray in the Ostomy Wound Management Journal, whereby they proposed a framework for categorizing evidence. And what they suggested in the article was that clinicians should primarily be asking 3 questions in terms of any new intervention to determine how effective that intervention may be in improving patient outcomes. And those 3 questions were, can it work, does it work, and is it worth it? The can it work relates primarily to scientific evidence, generating data in the laboratory, preclinical animal data, to demonstrate that the intervention, the medical device, the dressing can work. Does it work involves the clinical setting, testing the dressing in the real-life clinical setting. How effective is that dressing in the clinical setting? And then again, from a clinical perspective, is it worth it? So do the benefits of that dressing outweigh any associated cost implications or safety implications? So based on this framework, we looked at Aquacel AG dressing and the evidence that has been generated to date on Aquacel AG. And we can see the 3 blocks there: can it work, does it work, is it worth it? We can see that there is a lot of data, scientific data and clinical data today, supporting the use and benefits of Aquacel AG. So we start by talking about the science. And this is work that we've completed at ConvaTec over the last 2 years now, where we've tried to develop models, simple models, that very effectively demonstrate how dressings will be used in clinical practice. The particular model in this slide is what we refer to as a simulated shallow wound model. So across the top of this slide, you can see a cross-section of an agar plate. What we do here is to prepare an agar plate and then place sterile pieces of gauze on top of the agar. We then flood the agar with a second layer of molten agar, and once that second layer of agar solidifies, you can take the sterile gauze away, leaving this impression within the agar, and this is our standardized simulated shallow wound. So we can then fill that simulated shallow wound with bacterial suspension, in this case MRSA, and once we've inoculated that space, we can apply a dressing as it would be done clinically, a dressing in its entirety, normally a 10 by 10 or 4 by 4 inch dressing, such that it covers the simulated shallow wound area, but also fixes to the surrounding prominent agar. Thereafter, the plates are incubated for 48 hours, and then we look for the effect of the dressing on the bacteria beneath. And here you can see 3 different dressings, all silver-containing dressings, and the effect of these dressings on the bacteria that have been inoculated beneath the dressing. On the left-hand side, we see Aquacel AG dressing. There are about 3 colonies of Staph aureus remaining, so the dressing has been very effective in killing that quite dense population that was inoculated into the simulated shallow wound area. Across to the right, we see a silver-containing foam dressing, Alevin AG adhesive, considerable growth of MRSA in this simulated shallow wound area. We also see tracking of the bacteria onto the surrounding prominent agar. And then in the bottom centre, another silver-containing foam dressing, Mepilex AG, and again, considerable growth of Staph aureus in the inoculated area, and again this dressing has allowed the inoculum to spread onto the surrounding prominent agar, and we see growth of bacteria on the wound contact surface of this dressing. So the yellow there is actual growth of of Staph aureus on the wound contact surface of this dressing. So despite all these dressings containing silver, they don't all work in the same way. Again, looking at the Mepilex AG dressing example, where we see direct contact of the dressing with the agar plate, it's very clear that the dressing is not working, and this prompted us to do some further work, essentially taking away the simulated shallow wound and looking at the effect of direct contact of the dressing against bacteria inoculated onto an agar plate. We call this model simulated colonized wound surface model. It's slightly different. There is no simulated shallow wound area. So here you can see the dotted line across the plate. Below that dotted line we have a sterile layer of agar. We then pour another layer of agar on top, but this layer of agar in its molten state has been inoculated with a bacterium. It's been seeded with bacteria, so the bacteria are actually embedded within the agar. So if we then allow that second layer of agar to solidify and we incubate the plate for 48 hours, what you see below is what essentially you would see. Here we have, this is a multi-drug resistant strain of E. coli, and you can see when you look closely the colonies of E. coli actually growing in that seeded agar layer. So if we use this experiment, apply dressings to a seeded agar layer before the bacteria have had chance to grow, we can look at the effect of the dressing, in this case silver-containing dressings, on the bacteria in this 2 millimeter seeded layer. So here we have 4 examples of results. So if we look at the top left, Aquacel AG dressing, the zone across the top, that is the actual dressing. We've taken a cross-section of the dressing and the agar beneath. So this is the zone that was inoculated with multi-drug resistant E. coli, and there is no visual observation of colonies in this agar. If we go across to the top right, Mepilex AG dressing, then you can see E. coli colonies actually growing directly beneath the dressing. We see the same with a silver-containing alginate dressing, bottom left, that's silver cell non-adherent dressing, quite significant growth of E. coli there. And also with another form of antimicrobial dressing, Kendall AMD foam dressing. This is a dressing that contains PHMB, but again, you can see growth of the bacteria directly beneath the dressing. So again, all these dressings contain an antimicrobial agent, but if the relationship between the dressing technology and the antimicrobial component is not optimal, then the dressing is not going to be effective in killing the organisms, no matter how much antimicrobial agent you may have there. This prompted us to do some more work to see whether the internal components of the dressings that didn't work were able to work if we actually sliced the dressing in half. So we did this with Aquacel AG, and we did it with Mepilex AG using the same model, this simulated colonized wound surface model. So here, as you can see on the left, we have Aquacel AG dressing, and on the right we have Mepilex AG dressing. What we did here was to seed the agar plates with MRSA, and then before the bacteria had grown, we place a piece of Aquacel AG on the left-hand side of the left photograph, one face, the other face, and we use the edge of the dressing as well. Irrespective of the orientation of the dressing, we see complete kill of MRSA directly beneath the dressing. With Mepilex AG, we did a similar study. On the left-hand side of this particular plate, we have the wound contact surface of the dressing in contact with the agar plate. You can see growth of MRSA directly beneath the dressing. On the right-hand side of this photo, we have the upper side of Mepilex AG. So we do see some antimicrobial activity there. The top surface of the dressing was working more effectively than the wound contact surface. But then if we cut the dressing in two and place the edge of the dressing so that we're exposing the components of the dressing on the seeded agar, then the dressing works. So this indicates that silver is there, obviously. It kills the bacteria if you expose the contents of the dressing. But as the dressing is used clinically, then its ability to kill bacteria directly beneath is poor. Here we have another example of dressings being removed, again from another seeded agar plate using this colonised wound surface model. Here we've used a multi-drug resistant form of Pseudomonas aeruginosa. Pseudomonas actually produces a green pigment, pyocyanin, as it grows. So these are the dressings that have been removed after 48 hours. On the left-hand side, you can see Aquacel AG has been removed, and there is no growth of the Pseudomonas. Whereas when the AMD dressing was removed, Mepilex AG dressing was removed, we can see considerable growth and pigmentation of Pseudomonas actually on the wound contact surface of the dressing. So again, these dressings contain antimicrobial agents that should be effective, but the dressing technology may not be allowing those agents to be effective. So back to the evidence. So far I've addressed the efficacy part, the can it work, the scientific evidence to show that despite some dressings containing an antimicrobial agent, they don't all work in the same way. Moving on to the clinical aspects. Does it work? Is it effective? And is it worth it? Just like to finish by addressing two studies that have been performed on Aquacel AG. This one undertaken by Coutts and Sibbald, published in 2005, 30-patient study looking at non-healing wounds, a variety of wounds, diabetic foot ulcers, venous stasis ulcers, and also pressure ulcers. The outcome of this 4-week study was that 70% of the wounds decreased in size. There was a resolution of surface slough in the majority of the cases, and also a resolution of peri-wound maceration, all of which are indicators of wound progression. So the enhanced speed of wound progression is likely to be associated with a reduced cost of care. And finally, a study on diabetic foot wounds, non-ischemic diabetic foot ulcers, that was published by Jude et al. In 2007. Here, Aquacel AG was compared against a calcium alginate dressing, non-silver containing alginate dressing. And we can see on the left-hand graph here that over the 8-week period, Aquacel AG was associated with a near 63% reduction in wound depth compared to the alginate wound depth reduction of around 33%. There was a subset of patients in this particular study who had infected wounds. They were treated with antibiotics, and there was a statistical significant difference when the antibiotics were used in combination with Aquacel AG compared to the alginate dressing in reduction of wound depth. So the authors of this study suggested that there was synergy between this dressing and the use of antibiotics. So, key take-home message from this presentation is that topical antimicrobial agents are important, particularly with the increasing antimicrobial resistance that we're seeing in hospitals around the world. Antibiotics are less and less effective. So in wounds that are colonised with these organisms, the use of appropriate antiseptics are playing an increasingly important part. However, although these agents are effective, the combination with the dressing technology is also very important. And some of these combinations, as I've shown in this presentation, indicate that some of the dressing combinations don't work. Aquacel AG dressing is very effective. It readily makes silver available. It kills a wide spectrum of organisms, including the multi-drug resistant organisms that we're addressing today. Thanks very much for your attention.
Thank you, Phil. Our next speaker, Stan Monstrie, comes to us from the University Hospital Ghent in Ghent, Belgium. Professor Monstrie is chairman and professor of the Department of Plastics, reconstructive and aesthetic surgery in the Burn Center and Wound Healing and Tissue Engineering Unit. Professor Monstre has won numerous awards recognizing his fine work, and he joins us today to share his extensive research and clinical experience in burn injuries and wound healing. Dr. Monstre, please.
Good afternoon, ladies and gentlemen. The subject of my presentation is the non-surgical management of burn wounds, and more specifically, as you can see in the title, strategies for minimizing infection. Let me start with some background information. In the past 10 to 15 years, there has been a shift in focus from purely survival to more quality of survival after severe burn injury. And the quality of survival was related often to the quality of the scars. Scar formation after burn depends on many factors, but number 3, the local wound treatment is a very important one. Most of you must be familiar with the principles of contemporary wound management, which consist of debridement, tissue preservation, avoidance of infection, applying moist wound dressing, and allowing the wound to epithelialize or to heal. Specifically for burn patients, this consists of cleansing of the wounds, disinfection, and applying the appropriate dressing. Actually, the reason why we have all those sophisticated burn centers, and here you see some early pictures of our new burn center in Ghent, is the prevention of infection. What is it we want to achieve? We want to achieve healing like in this patient. Second-degree burn, it healed within 10 to 14 days, and you see the patient 8 months later, no scar at all. What is it we want to avoid? Here you see a patient with, as objectivated with laser Doppler imaging, a superficial burn of the face. However, infection occurred within 1 week, probably coming out of the oral area, and this resulted in delayed healing. It took more than 3-4 weeks, and we all know what is the result of burn wounds which take a very long time to heal. And especially nowadays, in times where the healthcare-related costs, also in Europe, it's similar to here, for all stakeholders, patients, insurance companies, national health system, is really exploding. We should avoid the extra costs of treating infection and correcting scars afterwards. So what have been our strategies to avoid infection in burn wounds? The major player has been silver sulfadiazine, also a silver-containing agent, which has been on the market for more than 40 or even 50 years, I think. And most of you must be familiar with the several advantages of silver sulfadiazine, but maybe you're less familiar with the also several disadvantages. It's a messy kind of dressing. Assessment of the wound is extremely difficult because of the layer, the sticky layer on top of the wound. There have been several reports of hair follicle death, retardation of wound healing, and even skin problems after wound closure. One of the major disadvantages is the fact that the dressing has to be changed on a daily basis. So maybe because of these disadvantages, several people have started to advocate that we should leave wounds more by themselves, that we should not focus too much on antisepsis, and that we should more use dressings, moisture-retentive dressings or semi-occlusive dressings, which can stay into position for longer periods. And in the past 10 years or more, we have seen many new, what we call high-tech, new wound dressings which have been put on the market. And one of them has already been mentioned by Phil, and which was Aquacel without AG. And our center, together with a center in the Netherlands, was involved in some early research. And actually, we were very happy to use Aquacel in the treatment of partial thickness burn wounds. But I must also confess that in certain patients, especially those with a little bit more extensive burn injuries and a little bit more deep burn injuries, we have seen conversions from superficial to deep burns, like in this patient, which ultimately had to be skin grafted. So, in our opinion, what is the ideal wound dressing for burns? It's a dressing which can be left into position for a prolonged period, but still has a slow-release antibacterial effect, and the best products on the market are, of course, the silver-containing products, of which you see two there. Let me give you a couple of examples. We were happy with the Aquacell. We were even more happy with the Aquacell Silver. Here you see a young boy with a second-degree burn of the thigh. LDI showed that it was a superficial burn. We applied one layer of Aquacell AG, and on the right slide you see a rather important detail of the application. The dressing shrinks a little bit afterwards, so you should always apply at least the layer till 5 centimeters out of the burnt area. Here the situation after 1 week, here after 2 weeks the dressing comes easily off, and here you see what we want to achieve after 7 months, no scar at all. Here another example in a young child, especially in these children where you put only one dressing. Of course, this is what we want. Sometimes the dressing comes off a little bit more difficultly, and it suffices to apply some Vaseline on it, and then you can peel it off very easily, as you can see here. And here the patient 14 days post-burn. We are very happy with the latest development in Aquacell AG, the burn dressing, which can be applied on more flexible or on more mobile areas like the hands. And as you can see, even after 10 days, when everything is drying up, there is more flexibility, a good mobility of both hands. So in our opinion, what are the advantages of Aquacell AG? No painful dressing changes, moist wound healing, a good adherence, antibacterial activity, no chronic inflammation, and what we think was a cost-effective treatment. We also use Aquacell AG to dress the donor sites, which are sometimes located close to the area which needs to be skin grafted, and this can be extremely useful on difficult areas such as donor sites of the scalp. This was a patient referred to us with an infected donor site, and we also treated this patient with Aquacell AG with good results. We even combined in heavily infected wounds the topical negative pressure therapy with Aquacell AG, and here you see the patient before and after. So we were pretty happy with it. We had the impression, to use Phil's words, that it can work, but this still does not mean that there is evidence that it does work and that it is worth it. So for this reason, we set up a prospective randomized controlled monocenter study in 100 patients. What was the purpose of the study? The purpose of the study was to compare a nanocrystalline silver dressing Acticoat versus a hydrofiber silver dressing Aquacell AG in the treatment of superficial to intermediate second-degree burns. Let me give you a little bit more details on the material and the methods. Out of a group of 350 patients, we were able to select 100 who met all the criteria of inclusion. And during the first 2 days, we simply treated them with an indifferent hydrocolloid paste and a paraffin or petroleum gauze. Why did we do that? Because burns, second-degree or partial thickness burns, are a very ill-defined group. And it has been shown in the literature that clinical assessment only is correct in only 60 to 70% of the cases. So if in this study we want to compare apples with apples and pears with pears, we need to be exactly sure what the depth of the wounds is. And therefore, after 2 days, we made a measurement with the laser Doppler imaging, of which it has shown that the accuracy of exact wound depth or wound healing potential is more than 95%. So what we did, let me show you what we did with the Aquacell, the 50 patients with the Aquacell AG. We applied 1 layer and applied also some dry sterile gauze dressing on top of it. The dressing was inspected every 3 days, and Aquacell AG was left in place until complete wound healing. I give you an example. A patient with a partial thickness burn on the thorax and 2 blue areas on the shoulders. Those areas were skin grafted, and the rest was covered, as you see here, the rest was covered with Aquacell AG. The values for healing potential more than 7 and less than 21 days was between 200 and 600. Here you see application of Aquacell. The deep burn was grafted. Here, the method of treatment for the 50 patients with Acticoat. We applied a moistened Acticoat dressing and a dry sterile gauze on top of it. The Acticoat, according to the manufacturer's recommendation, was moistened with sterile water twice a day. And dressing changes were performed every 3 days until complete healing. Here you see application of the Acticoat in a young child with a burn on the right arm. Here, second dressing inspection after 6 days, fourth dressing inspection 6 days later. Here, dressing change in that same patient with the Acticoat dressing. What was evaluated during those dressing changes? Of course, digital photography, cost report file, microbiology, wound swabs, nurse experience was registered, patient experience, and of course, maybe most important of all, the wound healing assessment was performed, and also some additional European questionnaires. Here you see Vaseline application and complete healing after 2 weeks. After 1 month after healing, 3 months, 6 months, and 12 months, we performed scar assessment with digital photography, assessment with the Vancouver Scar Scale, color measurements with the dermospectrometer, skin elasticity measurements with the Dermalab, and also health-related, specific burn health-related quality of life scores. Here you see the Dermalab for the skin elasticity, and skin erythema and pigmentation was measured with the dermospectrometer. So what were the results? We focused on variables and data collection in relation to research group consistency, of course, wound healing bacteriology, nurse experience, patient experience, economics, and scar quality. On the right side, you see a couple of pictures of the website, which was specifically set up and where all the data were put in on a weekly basis. Research group consistency. Again, if you want to compare apples with apples and pears with pears, you need 2 equivalent groups. And we were happy to notice that for gender, age, total body surface area burned, total body surface area of the target wound, and of course the flux mean values, there was no difference at all between the 2 groups. So we had 2 equivalent groups, also as to the causes of burns, which are almost identical, as you see in the 2 groups, and also as to the body areas treated into the 2 groups. Important, wound healing statistics. Of course, time of healing, also signs of infection, the number, and also signs of infection, the degree of the infection. And you see there were 4 degrees from none, mild, moderate, or severe. And of course, also having to do with wound healing statistics, the scar quality after 1 year. There was no difference at all between the two dressings as to mean healing time, as to the number of signs of infection, and as to the signs of infection. Late scar characteristics. Here you see already in this example that there is no difference between the two hands on the left side and the two hands on the right side. And indeed, if we look at the objective parameters, dermospectrometer, erythema, pigmentation, Vancouver scar scale, skin elasticity, no difference between the two groups. Next point, the nurse experience with the silver dressing. On each dressing, we measured the ease of dressing use, the ease of dressing application, and at the end, the ease of dressing removal, which was scored on a 5-degree Likert scale, coming from very easy to very difficult. Here you see at the left side the Aquacell and at the right side the Acticoat. What we actually often did was insert certain catheters. That way we could moisten the Acticoat without having to take off the secondary dressing. Here, there was a significant difference as to nurse experience in favor of Aquacell AG as to ease of use and ease of application. No difference between average ease of removal. As you can see here, we rather extensively scored or assessed the patient experience with the silver dressing, which is of course an important issue. Baseline pain, first dressing application pain, pain during dressing, worst pain score, itching, comfort with the dressing average, and also silver staining. For these patient-centered outcomes, there were again significant differences between the two, and again all in favor of Aquacell AG. No difference in baseline pain, but first dressing application pain was less for Aquacell AG. Same for pain during dressing inspection, of course. Worst pain score, comfort with dressing was higher with Aquacell AG. Itching was exactly the same. And the silver staining was also more pronounced in the Acticoat group. Last issue, statistics related to economics, number of dressings used, number of dressing interventions, total time spent, average time of dressing. Here again, significant differences in favor of Aquacell AG as to number of dressing, as to the amount of dressing used per square centimeter, the number of dressings, and the total time spent. The average time per dressing intervention was similar for both groups. And this brings us to my conclusions. First of all, laser Doppler imaging is an invaluable tool for patient selection in comparative burn wound research. And although the wound healing parameters, healing time and bacterial control were equivalent for both dressings, Aquacell AG scored a lot better because it required significantly less dressing material, less clinician time. It produced better patient outcomes and quality of life, and it required fewer dressings. So to come back to the questions of Phil, does it work? Yes, it does work, and yes, it is worth it. Thank you for your attention.
Okay, thank you. Our final speaker is Dr. Joseph Karam. Dr. Karam is a postdoctoral research fellow in adult reconstructive surgery at the Rothman Institute at Thomas Jefferson University in Philadelphia, Pennsylvania. Dr. Karam's current research includes infection prevention, diagnosis, and management in orthopedic surgery. Dr. Karam will be presenting the results of several new and exciting studies, including those performed at the Rothman Institute. Dr. Karam.
Thank you, Harry. And I'd like to thank ConvaTec for inviting me to this important event. So after seeing the specifics of wound infection and burn wounds with Professor Monstray, I'm going to address deep surgical site infections and total joint arthroplasty, which we call periprosthetic joint infections. So I will start my talk with a few epidemiological and statistical facts that we're witnessing now. First one is about life expectancy. So we are definitely living a lot longer now, and this data from the CDC shows that the life expectancy is on average 78 years now, whereas it was 47 years in the 1900s. So a little over 1 century, life expectancy almost doubled. And when looking at the proportion of the population which is over 65 years, of course, this varies by state, but this has been steadily increasing, and it's expected that in the year 2020, over 1/4 of the population will be over 65 years. Now, the other interesting fact is obesity. And again, data from the CDC shows that obesity has been steadily increasing in the US. And we can see that in men, nowadays, it is estimated that 40% of men are overweight and 30% are obese, leaving only 30% of men having normal weight or even underweight. And this study coming out of Northwestern University in Chicago shows that the estimated BMI in the year 2020 will be 30 in the US, and we all know that 30 is the threshold used by the WHO to qualify people as obese, so 30 will be the mean BMI in the US. Same study showed that more than 40% of the population in 2020 will be obese in the US. And I know that we have viewers from all over the world today, and this graph shows that the problem of obesity is not proper to the United States. It's all across the world. And in different countries are witnessing increase in obesity rates with more or less important slopes. This graph from the Canadian Joint Registry shows that 75% of total hip arthroplasties and 85% of total knee arthroplasties are being performed in patients who are either overweight or obese. And so the increase in obesity is, of course, leading to an increase in total joint replacements that we're performing nowadays. So both the increase in aging in the population, the increase in obesity, as well as many other factors, which I will not go into, are leading to a constant rise in the number of total joint arthroplasties performed. And many epidemiological studies have been realized in the past years to show that with projections. And here we have projections until the year 2030, presenting the results of a study conducted by the AAOS, which is the American Association of Orthopedic Surgeons, the American Academy, and studies based on the NIS, which is the nationwide inpatient sample data. And you can see that with this study by Dr. Kurtz, based on NIS data, that there has been a steady increase in both primary and revision total joint arthroplasty procedures over the past 10 years. A couple of years later, Dr. Kurtz's team published their projections for increases in total joint arthroplasty requirements, and you can see this exponential increase in the need for total knee arthroplasties, and it is estimated that in the year 2030, over 3.5 million total knee arthroplasties will be performed in the US. When looking at the procedure performed per age group in the population, we can see that the quicker increases are happening in the young age groups. Indeed, we are offering more and more total joint arthroplasty for young patients. The procedure has now become almost routine. It's a 34-minute procedure, and more young patients are demanders of the procedures, and they are getting it. And Dr. Kurtz also did a study dedicated to projecting the needs in young patients, and we can see the major increases in the need for total joint replacements in young patients in the upcoming years. So having more joint arthroplasties performed, especially more joint arthroplasties in young patients, will lead to an increase in the revision total joint procedures performed. And many patients are now outliving their prosthesis and requiring revision joint surgery. Also, projections for revision joint procedures, and you can see also the wide increase in the need for revision surgery in the future. And as you know, revision surgery is a much more difficult operation. It carries a much higher complication rate, especially infection, which brings us closer to our theme for today. So looking also based on national inpatient sample data from Dr. Kurtz's team, we have witnessed a steady increase in the rate of periprosthetic joint infection in the past years. So recently in the Journal of Arthroplasty, Dr. Kurtz published their data for projections and the rates of periprosthetic joint infection, and we can see this exponential increase in infected total knees and total hips. And when looking at the costs, it is estimated that we are spending today in the US over $800 million to treat patients with infected total hips or total knees. And when looking at the projections for the year 2020, it is estimated that over $1.6 billion will be spent just to treat infected hips and infected knee arthroplasties. So Bozek and Rees looked at the situation on a more case-by-case basis, and they found that when comparing revision surgery done for aseptic reasons versus surgery done for infection, there was a difference in cost of over $60,000, and that's just for one patient. Of course, apart from the cost, the economical impact, the infection has very dismal repercussions on the patients, and it has poor functional outcome for the patient. So why is infection on the rise? Many reasons can explain that. First of all, some results have shown that 80% of joint replacements are being done by surgeons who do less than 20 joints per year. And it is well known and has been shown in studies that centers with high load of joint replacements and surgeons who operate with a very high load of joint replacements have less complication rates. And this makes sense because they have shorter operative times, they have protocols in place to prevent infection. So this is one of the reasons for higher infection rates. Second one is that we're operating on more and more ill patients. In the older days, obese patients, diabetic patients were refused joint surgery. Now, as I said, the procedure has become much more simple, so it's being offered to almost everyone. No one is being refused a joint replacement. The emergence of resistant bacteria has been already discussed very long by Phil earlier, and it's one of the reasons. And better recognition of failure also plays a role, and also better reporting of the failures. So you must all be familiar with CDC, the Center for Disease Control and Prevention guidelines for surgical site infections. Now in the orthopedic surgery world, we're a bit frustrated with the current guidelines, which are from 1999. The guidelines are not based on evidence, not based on strong studies, and they do not address the specific needs of orthopedic surgery as well as each specialty alone. And we're happy to know that the CDC is currently revising their guidelines. They have been working on this for over a year now, and they are reviewing all the literature in order to come out with guidelines based on more evidence, based on high-level studies, and they're going to come out with guidelines that are specific to each specialty, orthopedic surgery, as well as other specialties. The scope of the problem now in every event, and I think Julie touched base on this earlier, is that there has been a push from the CMS, the Center for Medicare and Medicaid Services, to qualify periprosthetic joint infection as a never event, which means that if that event happens, the whole cost of taking care of that will rely on the shoulders of the hospital, of the institution, and they will not get reimbursed for that. And if that goes through, then this will change the whole landscape of how we view total joint replacement today in the US. So several studies out there have tried to establish risk factors for periprosthetic joint infections, one of which came out of the Rothman Institute in 2008, where they had a very large cohort. They looked at 10,000 patients. And the factors, some of the factors that always come up in these studies are wound complications. And these have been shown to be very strong predisposing factors to deep infection in the joint, so periprosthetic joint infection. Wound complications are unfortunately very rare, very frequent after total joint arthroplasty. They happen in around 20% of cases. They are more frequent in total knees, and precarious blood supply has been implicated as a major factor in those. So the best management for wound complications is, of course, prevention. Prevention starts with addressing technical factors. I know that currently in total joint replacement there has been a big push towards performing minimally invasive surgery, but the problem is that with a small incision, you need to do your procedure through a small incision. You put a lot of tension on the wound edges, and this compromises blood flow. This leads to a low quality of wound edges and can lead to wound complication afterwards. Another issue is with wound closure. Some studies have shown that subcuticular sutures, for example, are better for wounds with higher blood flow. And we all know that staples are very frequently used after total joint replacements. And some studies have shown that staples are not very good with wound healing, and they can compromise the quality of the wound. So it would be interesting to see what the new CDC guidelines will come up with based on current evidence. Prolonged wound drainage is a known predisposing factor for deep infection, and we know that wounds that drain a lot can lead to infection deep if not addressed early on. Blisters are also common in the orthopedic ward. Most of them are insignificant, they go away by themselves, but sometimes they can be deep, and when they crack, they can be a predisposing cause for infection. And some studies have linked blisters to the type of dressing that is being applied, which relates more to our topic today. Maybe these can be prevented with using dressings that are more gentle on the skin. So a few words about occlusive dressings. Studies have shown that these promote re-epithelialization and collagen synthesis versus non-occlusive dressings. And a systematic review taking into consideration over 100 studies showed that infection rates are almost 3 times less with occlusive dressings versus non-occlusive dressings. So this is one of the dressings we are here to talk about today, the Aquacel AG surgical dressing, which is currently being used in after total joint arthroplasty procedures. I will not go into the details about this dressing. These have been addressed by Phil earlier. But it has been designed to be gentle on the skin in order to prevent blistering. And the application of this dressing on the wound actually completely isolates the wound from the outside world. Now, this has many advantages, including, first of all, preventing bacteria from the outside to go in, whether from the patient's skin around the wound, whether from the hospital personnel, or from the air. Second of all, we are able to allow patients to shower directly after surgery with the wound on, and this might sound as an insignificant factor, but it's very important for the patient and for us to maintain good hygiene in the area and keep a clean environment. And third of all, having a wound completely isolated from the outside world promotes hypoxia in the wound. And this actually has been shown to be very beneficial because of hypoxia-induced factors, which are secreted by the cells and have antimicrobial properties. So having silver in the wound is actually a big attribute. Having silver in the dressing is one of the big attributes of this dressing. And silver has been gaining much popularity recently in total joint replacement surgery. And we know that some teams have been working on designing silver-coated implants for total knees and total hips to prevent infection of these implants. So this is a wound after a total knee surgery. The Aquacel comes in a sterile package, so it can be applied under sterile conditions in the OR. And it's very important to apply it properly in order for it to have its optimal effect. So there should be no wrinkles, it should be smooth surface, no communication with the outside. This is a picture applied to total hip arthroplasty. And we usually keep the dressing on for 5 days. It can be kept for 5 to 7 days. And when you remove it, you need to remove it very gently in order not to irritate the skin. So as Phil said, can it work? So of course it can work. We saw that it should prevent wound complications, and by preventing wound complications, it should also prevent deeper complications, since wound complications have been shown to be major factors for periprosthetic joint infections. But does it really work? And this is where the role of scientific studies come in. And I will be presenting 2 of those studies. The first one, which I'm primarily involved in, is taking place at the Rothman Institute under the direction of Dr. Sharkey. And this is a retrospective study looking at 1,900 patients, 1,900 consecutive patients, first group using standard gauze dressing, and then the second group using Aquacel dressing. The main outcome of that study is periprosthetic joint infection developing within the first 3 months after surgery. And to define periprosthetic joint infection, we used the new definition criteria established by the MSIS, the Musculoskeletal Infection Society, which have established uniform criteria to diagnose periprosthetic joint infection. So the results that we found were an 80% reduction in periprosthetic joint infection rates. Now, of course, when we first came out with those results, there were many critiques that how did you control for all the factors involved? This was a consecutive series. Were there any changes in practice? And these were very legitimate critiques, because there was actually a couple change in practice towards the last 3 months of the study, and we hadn't controlled for all the factors. So after we saw these amazing results, we wanted to have stronger proof, so we went and reviewed the whole 1,900 charts for over 35 variables, including age, BMI, and the 2 changes in practice, and did a binary logistic regression model, and found that Aquacel was an independent factor in determining a reduced rate of infection. Now, unfortunately, this webcast has been prepared several weeks ago when we had to send the slides, so we didn't have the results of that analysis yet. But I can assure you that the multivariate analysis model showed that Aquacel was an independent factor in reducing infection rates. The other study I would like to present is one conducted by Dr. Brian Springer in North Carolina. This is a level 1 prospective randomized study. It is expected to include 300 patients. Patients are being randomly assigned to receive either the Aquacel dressing or a standard dressing. And their primary endpoint is skin condition. And Dr. Springer was kind enough to share his preliminary results midway through his study. They have already enrolled over 150 patients, and they have already found statistically significant decrease in the incidence of wound complications, those being defined as blisters, wound healing problems, and prolonged drainage, as well as a significantly decreased number of dressing changes. They also noted an increase in patient satisfaction. One last set of results that I want to present is the clinical experience of Dr. Kuderna out in North Shore Hospital in Illinois. And he has been using the Aquacel dressing after total hip arthroplasty. And they found a decrease in surgical site infections, blistering, and the number of dressing changes. And most importantly, they found that after they used the Aquacel dressing, there were no cases where they had to delay the discharge of the patient because of wound complication versus with standard dressings. So in conclusion, periprosthetic joint infection incidence is expected to rise, and it's expected to rise in an exponential way. It already constitutes a large economic burden on healthcare resources, and this burden is expected also to be tremendous in the upcoming years. And the best way to prevent periprosthetic joint infection, the best way to manage it is by prevention. And by acting on the wound complications, which are a major predisposing factor for deep infection, the Aquacel dressing has been shown to prevent periprosthetic joint infection. So can it work? Again, after total joint arthroplasty, it appears to be able to be very efficient. Thank you.
Okay, so now is when the fun begins, and we are concluding the didactic presentations. We're now going to open the discussion to the audience for our live questions and answer session. For those participating in this webcast remotely, please type your questions in the question box located at the bottom of your computer screen. I will do my best to appropriately address the questions to the right panel member. I promise. But I encourage any panel member who can contribute to the response to speak up so the audience can benefit from the wealth of knowledge and experience represented here today. So I'm going to open it up now, and I'm going to get the first question. And the first question is, I'm going to send this to Julie. Given that the U.S. health reform law has been a major driver of efforts to address HAI, health-associated infections, and establish penalties on hospital, what effect might the U.S. elections have on these efforts? You don't have to declare who you're voting for. If President Obama is reelected, will these programs fade away? And that was from someone in the United States.
I think I would start answering that by saying that it's very unusual for anything to not be politically charged or hostile in a political manner in the United States, and this area might be the only exception. I think that regardless of who takes over the reins of the White House and whoever's elected to Congress in terms of the majority, these issues are very much alive and will transcend politics completely. You know, healthcare expenditure growth and the association between these infections and the significant growth of health expenditures is something that has to be addressed. And regardless of which political party is in charge, it's on the minds of all of them. So I think that regardless of who wins in November and what happens, we'll continue to see these programs persist. The focus on readmissions and criteria, the focus on reining in infections, and the penalties that are applied.
Okay, thank you. Dr. Monstre, I have a question for you. Do you use Aquacel silver dressings for every burn wound, or does it depend on the patient or type of burn? How do you make your decisions that it is necessary?
I must say that's a good question, because as I mentioned in the beginning, we were very happy with the simple Aquacel dressing. So we were like wondering, is it really necessary each time when we have a burn to use the Aquacel AG where silver is added? And I must say, although we haven't seen that much of infectious complications with Aquacel, I think nowadays where you cannot allow almost one single infection, it is better, and this is what we do, also because of legal arguments, it is better to apply Aquacel AG on every burn wound, which is what we do.
Okay. Thank you, Dr. Monstre. The next question, Dr. Karam. This comes and it specifically wants to know how all the variables that can contribute to the SSIs, how were they controlled for and ruled out as a causative factor? You spoke about there were 35 variables you looked at. Can you possibly walk us through how that happened, how they were looked at each one?
Yeah, of course. As I said, we reviewed the whole 1900 charts, looking at around 37 variables, I guess. And all the variables were incorporated in logistic regression models. And as you know, it's a stepwise model, so you keep eliminating factors until you keep the factors that are really contributing to the outcome, which was acute periparesthetic joint infection. And we tried several models, and in all the models, aquacell dressing still remained a very significant factor, with p-values averaging 0.01 to 0.02. Of course, other factors were implicated, were demonstrated to have an effect on the infection rates, like thyroid disease or age, or the ASA score. But the aquacell dressing was shown also to be a significant factor in affecting the infection rates.
So, Phil, a question for you. You've done a lot of studies, worked on a lot of different topics, comparative effectiveness, random control trials. Is there anything you want to contribute to looking at a study when there's so many variables? Is your experience along the same lines, or is there something you'd like to speak out on this topic? It's a in-depth question, and I think an expert like yourself would be well served to hear from you.
Well, I think when you do have studies where there are so many variables, I think that's where scientific experimentation plays a big part. Again, if you look at microbiological studies on wounds, the variabilities in doing the microbiology alone are so great that how relevant, how valuable is the data that you're going to generate. So I think there is benefit, obviously, for clinical studies, but also scientific studies. Scientific studies are performed in a much more controlled environment, where you can directly compare one treatment, one dressing against another under very, very controlled conditions that you can't always achieve in a clinical situation.
Okay, thanks. Julie, I have another one for you. You spoke a lot about hospital-acquired infections. Are these policies impacting other care settings, such as nursing homes, doctors' offices, clinics, and other care settings? If they are, when do you think they're coming?
I think we can expect that they will come forward. The focus at this point has, as I talked about, been significantly on hospitals and specific measures that have to be met by hospitals or face the risk of penalty. What we've seen in the United States thus far has been a tremendous amount of work around guidelines and providing resources to other types of healthcare settings on how they can control and prevent infection rates. But I see this becoming, transcending across different types of healthcare structures. Again, this issue of how we control healthcare expenditures and the recognition of these infections being preventable in nature make them a target. So I expect that we will in the near future. But a lot of these programs that we're talking about that are happening at the hospital level are fairly new, some of them just going into effect. So I think it'll take some time.
Okay, thank you. So, Phil, you have a little leeway on this question, and it comes from Mexico. And the question is, what are the most common bacteria in wounds? And feel free to steer or navigate down this path as you see fit, within the limitations.
Well, it depends what wound type, of course, and it depends what techniques you use. In chronic wounds, there are vast numbers of different types of organisms. Common bacteria, obviously, organisms I referred to during the presentation, Pseudomonas aeruginosa, Staph aureus, many anaerobes. We've published a lot of work on anaerobic bacteria in wounds, and they do in many instances outnumber the number of aerobic bacteria. So organisms such as Bacteroides and also Clostridia are also very common in surgical wounds, acute wounds. Then it's the Staphylococci that are generally most problematic. But then, as I say, it's the techniques that you use. So in the laboratory, if you use traditional microbiological techniques, you may pick 5 or 6 different organisms from a chronic wound, but if you use molecular techniques, you could be picking out 60, maybe 20 different types of organisms.
Okay, thank you. Dr. Monstre, how is Vaseline used to remove the Aquacel AG, and did you put it under or on top of the dressing?
Indeed, let me start by saying that in certain patients, like after 2 weeks when the Aquacel is still on the wound, although it is healed underneath, sometimes it comes off by itself, sometimes you need to peel it off. And especially as the example I showed where we're dealing with a small child, we try different things to ease the removal of. And what we did, we put Vaseline on top of the Aquacel, and we apply a couple of layers, often even the day before we think that the dressing should be removed. And after applying 1 or 2 layers of Vaseline, the dressing can be it softens and it can be easily taken off without problems. But we put it on top of it.
Put it on top of it. All right. Let's do a follow-up question for you. In your presentation, you showed a case of a head burn injury. What type of dressing was that? We often have challenges dressing a hand. How did you get the dressing to be shaped around the hand? So it's 2 questions: the head burn injury, what type of dressing, and how do you get the dressings to shape around the hand?
Okay. The first dressing, indeed, I must say Aquacel AG is our favorite dressing for all kind of second-degree burns. But like the child you saw with the burn in the face, there, of course, it's rather difficult to apply. And I must say in this child, and we consider this as another argument pro Aquacel AG, in this child we applied an hydrocolloid dressing in which we even mixed a little bit of iodine, betadine. But still, we had some infection. So the second part of the question was?
About the dressings on the hand. How was it to put them on the hand? Did you use anything else to secure them to the hand? Was there another dressing put on top of it?
Well, we used to just apply, like on every other burn wound, the Aquacel AG on top of the burned area. But especially after 10 days, after it had dried up, you had that rather immobile crust, which made it difficult for them to move their hands. And now although we only have a limited experience with the new Aquacel AG burn, it has a different structure. And indeed, when we apply it on knees or on elbow regions, or even, which those are very handy, the gloves, you can just put a hand in, and this allows a complete coverage of the burn, and at the same time, from the beginning till the end, they're able to move their hands, which is a substantial advantage.
Okay, thank you. Dr. Cram, we have another one for you. How long from most surgical incisions can the Aquacel dressing stay in place without having to change?
So Dr. Sharkey leaves it on for 5 days, and from other surgeons' experiences, they usually leave it on for 5 to 7 days.
Okay. And I'll address the question about when to change. When do you change it if it has to be changed on the floor? Is there a protocol that the nurses use other than what the indication is, the saturation? So when it gets to the borders in your hospital, they change it. Is that correct?
Yeah, but usually the patients are already, like, they're not on the floor anymore, because after total joint replacement, they're only in the hospital for 2 days. So either in the clinic or with the home nurse, they can remove the dressing.
So when they transition from the acute setting to home, they're giving instructions to take it off at 5 days?
Yeah.
Is that correct?
If they are sent, for example, to rehab facility, we know that some rehab facilities have protocols where they have to change the dressing after 48 hours, or they have to change it every 24 or 48 hours. So they send them off with very clear instructions not to remove the Aquacel dressing before the 5 days.
Okay, thank you. Okay, Phil, how do we diagnose biofilm in chronic wounds clinically and in a laboratory? I know this was not in your topic today, but it seems to be, we're getting a rash of questions about this. So can you enlighten us?
Okay, yeah, there's certainly a lot of debate about biofilm today in terms of the role of biofilm in wound healing and whether or not you can actually visualize biofilm in wounds. Of course, biofilm is actually produced by the bacteria that colonize the wound, so it's tissue that doesn't belong to the host. And if you document the life cycle of biofilm development, then obviously microorganisms are microscopic, they attach to a surface, they start to secrete biofilm, and if that growth is not impeded in any way, then the microscopic colony will develop into a macroscopic community that is visible to the naked eye. So biofilm can be visualized, however, there are many factors within wounds that affect how easily biofilm can be observed. So if it was, for example, a non-healing acute wound where there may be a cloudy translucent sheen on the film, then the likelihood is that is biofilm. In more complex chronic wounds where you have lots of different types of tissue and colours in the wound, then it's much more difficult. So how do you identify that? Probably takes a trained eye. Biofilm, certainly biofilm in the mouth, for an example. Bacteria on the teeth produce dental plaque. Plaque is biofilm, and disclosing agents are used to actually show up the dental plaque. Ideally, such an agent for wounds would benefit in terms of better visualization. In the laboratory, then it is more sophisticated equipment. It's still generally microscopy that is used, quite sophisticated microscopic equipment that's used to confirm that biofilm is actually present.
Okay, thank you. So this question is gonna, we're gonna go across our board here, and I'll start with, this is from the United States, but what is the key, what is the preventative key to preventing wound infections? So Phil, can we start with you? What is the key to preventing wound infections? You can start in vitro if you want.
Yeah, I think I've addressed it partly today. Overall, of course, it's good wound care. So it's not just a matter of applying an antimicrobial dressing to a wound and assuming that dressing will prevent the infection, especially in a chronic wound. Then the protocol of care is very important. Identifying biofilm, removal of devitalized tissue, cleansing of the wound as best possible, and then application of an appropriate dressing. It may be an antimicrobial dressing, it may not be, but I think it is very much a protocol of care approach to minimising the opportunity for infection. But then there are many factors again that can affect. So if an individual is immunocompromised, the risk of infection is much greater, of course, and certain organisms are highly virulent and can cause infection very quickly. So again, it's a situation where there are lots of different factors that can affect this, but I think good protocol of care is a good starting point.
Okay, thank you. Yes? Oh, I'm sorry.
Hello?
Hello, Dr. Salmon, how are you?
Well, thank you. I have a question for Phil. The auger plates that you showed with the zone of inhibition or the zone of clearing, did the dressing fit right over that, or is there kind of a circumferential clearing around the dressing like there is with an antibiotic disc? And does the silver penetrate deep into the auger, but if it doesn't penetrate laterally also?
Okay, well, yeah, the experiments that I showed here weren't necessarily zone of inhibition, but certainly if you place a piece of Aquacel AG on a surface inoculated plate, then you will get a zone. You will get a zone around it, so there'll be no growth beneath the dressing, and you will get an extended zone of inhibition. Depends on the type of organism, of course, and like antibiotic susceptibility discs, the zones vary according to the type of organism against a particular antibiotic, and you will see the same with a dressing such as Aquacel AG. So yeah, if you place it on the plate as you would do with a disc, an antibiotic disc, then you will see a zone of inhibition. And
So-
your second question, sorry?
Oh, no, I just want to know if the dressing was smaller than the zone that we saw. The dressing that you put on the plate was smaller, so we were actually seeing the area underneath the dressing plus the zone of inhibition.
No, you didn't see the zone of inhibition on that particular, in this particular model. But your second point was the dressing killing the bacteria within that layer? So was it penetrating to a degree? And yes, it was.
Thank you.
I think we have another question from the audience, Dr. Dysart.
Dr. Karam, many of our new technologies have to go through value analysis committees in our hospital systems in the U.S. Have you looked at the economic model in terms of the Aquacel AG dressing you're using? It looks pretty compelling from reducing nurse work hours in terms of managing the dressing, but the actual economics, have you looked at that?
In our study with Dr. Chucky, we haven't really looked at economic implications yet in detail, but I know that from other studies they have shown that there has been a decrease in dressing changes, and of course this takes off of the nurse's work. But the major economic implication is by preventing infection, and as I showed, the cost of infection is really huge. So I think that the major economic implication is by reducing infections and saving all these expenditures spent on treating joint infections.
Okay, we have another one from the audience.
Clinically, when we put those dressing, it's for patients who have at least a minimum of exudate. So in the in vitro model, when you put those dressing directly on the agar, do you think that since some of those dressing needs a moisture or an exudate to, I think, be fully efficacious, do you think that having put a small layer of serum or serum-like liquid would have maybe make a bit of a difference in the inhibition of the bacterial growth?
Yeah, valid point. Absolutely. With any dressing containing an antimicrobial agent, the dressing needs to be, certainly with silver dressings, needs to be hydrated for the silver ions to become effective. In the agar model that we used, the majority of the composition is water, about 98% water, and we'd looked at that prior to the experiment, in that the water within the agar is sufficient to fully hydrate the dressings to activate the silver.
Thank you.
Any more from the audience? Yes? Can we get the microphone? Young man.
Yeah, thank you for the great presentations. Just a question about the wound infection. I think a lot of cases you present talked about here acute wounds. So think about chronic wounds and looking at the continuum of bacterial burden from contamination, colonization, critical colonization to wound infection. I wonder if the panel can comment on the cost effectiveness of using silver in the sort of pre-colonized stage versus the actual treatment of wound infection, because I've been hearing the message that perhaps if we use silver dressing a little bit earlier, we can prevent infection and save money. So from a chronic wound perspective, from a lot of wounds that are colonized already, should we wait until we see obvious signs of infections versus the early use of silver dressings?
So, well, I think Professor Bola, that has your name written all over it.
Yeah, in my presentation, I did talk about the physical properties of dressings that may help to control infection, and I think that's an aspect that should be considered at the outset. So if a wound is merely colonized and there doesn't appear to be any significant risk of infection, then it may be inappropriate to consider using a silver dressing. So hydrofiber dressings such as Aquacel alone that can absorb exudate bacteria and immobilize the bacteria in the dressing, that may be sufficient in a colonized wound. I think if there is clinical concern that that wound is progressing towards infection, then I think there is absolutely value in using an appropriate antimicrobial dressing to, again, as I referred to in the presentation, to control the bioburden and stop it to progressing to a stage where it's likely to result in infection.
I agree. I would say we mostly use Aquacel AG to prevent the critical colonization. And it is a little bit our opinion that especially when you have a critical colonization and a wound, an infected wound, that maybe at that point silver dressings could maybe not be the best way to go. I see it rather in the prevention of critical colonization rather than when you have a critical colonization or an infection to start treating the wound then.
Okay, thank you. Unfortunately, we are going to have to close our session. This will conclude our live question and answer session. On behalf of ConvaTec, thank you to all the speakers for sharing your time and expertise so that we may have a better understanding of how to meet the challenges of wound infection. And thank you to our audience participating here in Washington, D.C., and to those participating from around the globe today. This now concludes our webcast. Thank you. It's not on. Okay, we're gonna take a 15-minute bio break, and then we're gonna come back for a open question and answer discussion with the panel. So 15 minutes, 5 to 3. So let's be back in by 3:10.